Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This Journal of Clinical Oncology podcast provides observations and commentaries on the Journal of Clinical Oncology article, The Combination of International Staging System 3, High LDH, and Translocation 414, or deletion 17p, identifies patients with multiple myeloma treated with frontline autologous stem cell transplantation at high risk of early multiple myeloma progression-related death by Philippe Moreau and colleagues. My name is Maury Gertz, and I am chair of the Department of Medicine at Mayo Clinic, Rochester, Minnesota. My oncologic specialty is monoclonal gammopathies. In 2013, 22,350 patients in the United States were estimated to have developed multiple myeloma. This represents 1.3% of all new cancer in the United States. It is projected that 10,710 patients will die of myeloma, representing 1.8% of all cancer deaths. It is now estimated that during one's lifetime, 0.7% of men and women in the United States will be diagnosed with myeloma. Fortunately, due to the development of novel agents, the 5-year survival rate has doubled, and for the years 2003 through 2009 is 43%, making it the 15th most common cancer in the United States. This compares with non-Hodgkin's lymphoma, diagnosed in 69,700 annually, ranking number 7. The median age at diagnosis is 69 years. The median age at death is 75 years. The rate of new myeloma cases has been rising 0.7% annually over the past 10 years. Although the gains in survival and quality of life have been impressive, all myeloma patients have not shared in these advances. It has long been recognized that a subset of patients either will not respond to therapy or have responses that are not durable and lead to early relapse. Even with high-dose chemotherapy and stem cell replacement, responses are short in this group. The recognition by the National Cancer Institute's Myeloma Steering Committee of this subgroup has led to the development of 2 national trials with eligibility defined by biologic risk. The first trial is for standard-risk multiple myeloma patients. Patients are randomized to either bortezomib, lenalidomide, dexamethasone, or carfilzomib, lenalidomide, dexamethasone. The S1211 trial is specifically designed for high-risk patients and is a randomized phase 1-2 comparison of bortezomib, lenalidomide, dexamethasone with or without the anti-CS1 antibody elotuzumab. The endpoint of this study is progression-free survival at 2 years. A major challenge in multiple myeloma is defining which patients actually constitute high risk. The International Staging System for myeloma, and most staging systems for that matter, are designed to separate patients into groups with marked differences in median survival. Staging systems of this type make it possible to compare the composition of patient groups across phase 2 trials and provide a sense of the effectiveness of therapies in otherwise heterogeneous groups. Staging, however, does not necessarily identify specific risk groups. The International Staging System is an extremely simple classification that has been validated both with conventional and novel agent-based chemotherapy, with or without stem cell transplantation, and in the United States and Europe. The definitions are based on the serum albumin and the serum beta-2 microglobulin. Stage 1, serum albumin greater than 3.5 grams per deciliter, and beta-2 microglobulin less than 3.5 micrograms per milliliter. Stage 3, beta-2 microglobulin greater than 5.5 micrograms per deciliter. Stage 2, all other patients. This highly reproducible system separates patients with dramatically different outcomes and has repeatedly been shown to carry predictive value both for progression-free and overall survival in multiple myeloma. Unfortunately, this staging does not identify the high-risk subset that is destined to do poorly with conventional induction therapies used for multiple myeloma. In this trial, investigators from France, Italy, Spain, Germany, and the Netherlands pooled their data to construct a prognostic index and then subsequently developed a validation data set based on prospective randomized trials in 1,687 myeloma patients. Their data reaffirms the value of the international stage in identifying poor prognosis patients. However, they were able to identify a particularly aggressive subset of patients constituting 8% of newly diagnosed multiple myeloma, in whom, despite high response rates to therapy, had very short progression-free and ultimately overall survival. Patients who died of treatment-related complications, such as neutropenic sepsis, were excluded. The focus was on those patients whose death was directly related to the aggressive biology of their disease. When applying their high-risk staging, and including only those patients who received bortezomib-based induction therapy, this high-risk group had a 2-year overall survival of 51.9%. This poor prognosis group was not due to disease resistance. Less than 1/4 of the patients were refractory to induction, and over half had a partial response following induction. Rather, these patients, despite being responsive, rapidly relapse, leading to their death. Their system is relatively easy to apply in clinical practice. 1 point is assigned for each of the following variables. 1, beta-2 microglobulin greater than 5.5 microgram per ml. 2, an LDH level greater than the upper limit of normal. 3, FISH cytogenetics on the bone marrow demonstrating either translocation 414 or deletion 17p, genetic changes that have been known markers of adverse outcome for nearly a decade. Using this system, patients can be divided into 4 groups having either 0 points to 3 points. Patients with a score of 0, 1, 2, or 3 points had a 24-month overall survival in the pooled randomized trials of 93, 86, 73, and 52% respectively, highly significant differences. In conclusion, this model, identifying 8% of newly diagnosed myeloma patients, have a very poor prognosis and are at high risk of a disease-related death despite the use of the most effective drug combinations known, and allow these patients to be referred for new innovative interventions to treat their multiple myeloma. Serum beta-2 microglobulin, serum LDH, and FISH genetics on marrow samples should be performed on all newly diagnosed multiple myeloma patients. This concludes this Journal of Clinical Oncology podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.